for pairing, you should see a box in the top too.
Fantastic. Okay, welcome everybody. And this is our Prostate Cancer Survivorship Series brought to you the MIU Men's Health Foundation. We hold these events on a regular basis, usually approximately 3 times a year. And we're also blessed to have wonderful panelists, and we'll talk about them in a little bit. 2023 was a great year for the foundation. We were able to hold all of our events in person. We had everybody together, and we had our Blue Monday Men's Health, which was celebrated across the country with some of our partners at Solaris Health. We also had our Cogs and Kegs event, which was a record number of individuals who attended our bicycling event over at Griffin Claw in Birmingham. We had over 300 cyclists join us for an evening of celebration of men's health advocacy and survivorship. And then later in the week, we had our Mulligans for Men at Top Golf. And as well, we had our Run for the Ribbon at the Detroit Zoo, celebrating prostate cancer survivorship for men and their families. Later this year, we held our event at Ford Field, our annual men's health event, in which we had a record number of 1,400 men take advantage of the free health screenings and opportunities to learn about the needs of their health and well-being, not only to get healthy, but to stay healthy. And we're very proud of our foundation having achieved all of these events throughout the year of 2023 due to our sponsors and partners who continue to support all of our efforts as we reach out into our men's health community. Tonight, we have sponsors who are supporting our Prostate Cancer Survivorship Series. Those include Boston Scientific, Neil King Physical Therapy, Lantheus, Planet Fitness, Blue Earth, and the American Cancer Society. If you wish to see some of our other prostate cancer survivorship events, you can feel free to go to our MIU Men's Health Foundation YouTube channel, which all 15 years of our prostate cancer survivorship events are actually logged and waiting for you to see. And on that note, I'd like to get started. So a little bit about prostate cancer. Prostate cancer represents over 1 million cases that occur yearly in the United States and across the world. Just in the United States, we have over 200,000 men being diagnosed with prostate cancer. And the question is, who's at risk? And so we know that men, as they get older, are at increased risk. Men of African descent, men who are born in certain countries are at higher risk. And if they move from those countries, will actually get even in higher risk for those countries that have higher incidence, such as here in the United States and in Scandinavia. If you have a family history of prostate cancer, you can increase the risk of prostate cancer and other male consorts within the family. And also we know that firefighters and fighter pilots are at increased risk for prostate cancer and developing it in their lifetime. So if you're a man of increased risk, you should pay attention and get screened appropriately. If you are here and you have family members who are listening in, you should also let them know that they are at increased risk and should get screened appropriately. You know, tonight we're going to talk a little bit about the treatments and side effects of the treatments for prostate cancer. Urinary incontinence can occur in prostate cancer therapies, whether it be through surgery or radiation therapy for local curative therapy, and can remain for up to 10% of men after even a year of recovery. Also, erectile dysfunction is something we'll talk about tonight as well, and 25 to 75% of men may have some degree of erectile dysfunction after their primary treatment, and we'll talk about that as well. Some of the things we'll talk about is being proactive and not being reactive for patients and their care, as well as looking at a team approach and how we can all work together to improve survivorship and the quality of life for individuals who actually choose some type of local therapy and wish to move on and have a better quality of life. So tonight, I'd like to introduce our 2 panelists that we have tonight. First, Dr. Tina Schaffner. She is from Neil King Physical Therapy. We've actually talked on many occasions about prostate cancer patients, as well as just life in general. Tina, I'd like you to introduce yourself and tell a little bit about yourself and your history.
Well, good evening. Thanks for having me here, and thanks for inviting me. It's always a pleasure to be part of one of the Men's Health and MIU events. I do present at the in-person one that we typically have at, I think it's at the Troy office. So this isn't my first time presenting to a group of gentlemen who've had the surgery and their families. So I'm a physical therapist by day. I have been for 20 years. Part of that, half of that has been in pelvic health, I guess. It used to be called mostly women's health, but now they're trying to pelvic health to include the men. And by about 10 years ago, I had a coworker start the program, and she left the clinic to go find love in Baltimore, which left me with this public health program. So I started to get involved. It wasn't something that I originally went to PT school to thought I'd get into. And my very first patient's name was Ted. And I was hooked when he walked in after a few visits and said, "Hey, Ted, how's it going?" He's like, "I've got my big boy pants on." And I was hooked. I have been working with men. I do work a lot with men because there are not a lot of pelvic floor practitioners in the area that will work with men. It has been a fairly isolated women's program for years. So at Neil King Physical Therapy, I strive to have all of our pelvic floor specialists work with men as well. So we do everything. We do back pain, leg pain, hip pain. Cancer doesn't affect just one part of your body. It affects the whole life. So we're able to treat patients across the gamut, whatever their functional limitations are, to get patients back into doing what they like to do. And that is our bread and butter. We love all of that. So thank you.
So I know you keep advancing your training, and I notice you have a doctorate in physical therapy. Tell me a little bit about getting a doctorate in physical therapy, and what are some of the different levels of certification that maybe people should look for when they're choosing their physical therapist?
Yeah, for sure. So I got a little bit lucky. So when I went to PT school, that's when the physical therapy program relative to curriculum was transitioning from a master's degree. And the goal was by 2020 to have all the programs in a master's degree or a doctoral level program. Well, the year that I was admitted, I went to U of M Flint for my PT to school. I went to U of M Ann Arbor for undergraduate and U of M Flint for PT. And they were getting recertified as their program on a whole. And so when CAPT came in, and that's the company that certifies the program, stated, "Why aren't you moving towards a doctorate?" Our directors basically stated we were waiting for that go ahead. So we got certified as a program. U of M Flint got certified as a university to hold a doctoral level program. The university has to have certain services in order to even have that capability. And I was transitioned, and I got a choice. I either got to graduate with my master's or graduate with my clinical doctorate. And so I obviously chose to go the clinical doctorate route right then and there. It was easier at the time to do that than to have to go back to school to get it. The difference is the differential diagnosis. U of M's program was already fairly complete. I had to add a differential diagnosis class for kids and adults. And there was one additional class. There was a capstone progress or a capstone project that I had to do that was a little bit different, but otherwise the program was already in place. So basically I just had to make sure that when people came to me, I made sure that the issues they were coming for, their back pain was actually related to musculoskeletal system, not, bone cancer, not their heart problems, not because they've got kidney issues or some other issues. So relative to a PT, whether you have somebody with a master's with a lot of, even people who have masters now have great, they've learned a lot of that stuff with experience. What you're really looking for is a therapist who will sit down and take their time to listen to you. Patients really know their body best. And if you take a thorough, and this is probably across many medical professions, if you take a thorough history, most patients will tell you exactly what the problem is, and it'll get you down the right direction. So that's number one. Relative to pelvic floor, you want to make sure whoever you're seeing, has actually taken courses. PT school and the education in PT school is inadequate to train and work with patients with pelvic floor dysfunction. You could do more harm than good actually in that environment. So if you're choosing to go to physical therapy, specifically for pelvic floor dysfunction, you want to make sure whoever you see has taken certification courses. They've taken multiple levels of them. They've taken courses that are directed at men, women, not necessarily children, but also need to take courses relative to how to manage pain so that your care is comprehensive.
Thank you for being here, and thanks for the explanation. Dr. Sandberg, Jason and I, we work together over at the Michigan Institute of Urology. Actually, we work down the hallway from each other, and we get to make faces at each other all day and smile and grumble together sometimes. But he's also volunteered to help us out. He's done this on more than one occasion, and we always appreciate having you here. I'd like you to share, though, a little bit about yourself, some of your background, but more importantly, your fellowship subspecialty training.
Sure, Dr. Lux, thanks again for having me back. I think I always enjoy being able to participate in the seminar because a lot of what we're talking about tonight is what I do in my day to day. And so, like Dr. Lux mentioned, I'm one of the partners at Michigan Institute of Urology, and I also, in addition to training and getting my finishing a residency program in general urology, Also did an additional fellowship in reconstructive urology and prosthetics. And during that fellowship, we learned to treat a variety of different conditions that may or may not be related to men with a history of prostate cancer and some of the issues they might be dealing with subsequently. But my particular experience dealt with men related to prostate cancer who then go on to develop issues like you already mentioned, including erectile dysfunction and importantly, urinary incontinence. The treatment of those, both of those issues tends to go in a bit of a stepwise manner, I would say. And there are behavioral things, there are physical therapy things, there are medical things, and there are surgical things that can be done to treat those conditions. And I specialized in the medical and surgical treatment of those conditions. And so in particular, there are devices that have been created that have been around for decades at this point that are reliable and help men quite a bit when they have more severe cases of erectile dysfunction and incontinence, and that oftentimes requires surgery, and that's what I help guide them with. We talk about what is the effect of the side effects from prostate cancer treatment on them, not only objectively but subjectively, because one man's experience with incontinence, for example, is totally different than another's, even if they're technically leaking the same amount of urine in a day. One man might be very distressed by it, and another man may not. And there are different ways to manage that. And so it's important to sit down and as Dr. Schaffner spoke about earlier, to listen to the patient and really to understand what they need to help them achieve their goals and live the best quality of life. And sometimes that means surgery, and sometimes it doesn't. But when it does mean surgery, we've got the specialized training, and I have the specialized training to help them with that. And that's what we do.
Thank you. Thank you so much. Thanks for being here. So I'd like to address my first question to you, Dr. Sandberg, about being proactive. A lot of times patients come to us and they're newly diagnosed with prostate cancer. So my question to you is how do you counsel them with regards to choices and risks, and how do you approach it in that fashion?
Sure. I mean, I think it's very important, first to acknowledge that a diagnosis of prostate cancer is very scary, for a man. And oftentimes the first question, rightfully so, is, okay, what do we do next? How do we treat this cancer and how do we cure it? But I find oftentimes when men are so focused on that, oftentimes the conversation can sometimes be overlooked in terms of, all right, well, once we do that, then what is the potential aftermath? And many men do very well and don't, fortunately, they don't deal with these issues, but a significant number do. And so I try to talk to them about whatever treatment they may be choosing, whether that be radiation therapy or removal of the prostate surgically or cryotherapy or whatever it might be, to think about what their life is going to look like afterwards. And sometimes, we can't exactly predict in any individual man what those side effects might turn out to be, but we can at least help them to set themselves up to be as successful as possible. So in terms of being proactive, it's important for men to get in shape, and to understand that physical fitness, core strength, good nutrition is really important to the success of their prostate cancer treatment, but also to the potential success and avoidance of such side effects that we've talked about already afterwards.
And just out of curiosity, we were talking about being proactive. Do you think there's any role for pre-treatment counseling or evaluation?
Yeah, absolutely. I do, for that very reason. I mean, I think that, a lot of men's urologic oncologists can walk them through that, but oftentimes there may not be a time in a single visit to discuss both what needs to happen in the moment to treat the cancer or in the very near future, and also what to consider afterwards. And so counseling men on what to expect, what rates of erectile dysfunction and urinary incontinence may happen, what their postoperative course or post-treatment course might look like in terms of timeline of potential recovery of these things, because many times men might experience leakage, for example, in the first few months, but then regain continence. To help them think through, well, if I choose radiation, what might a worst case scenario look like in terms of side effects versus worst case scenario in radical prostatectomy versus most likely scenario. And I think because a lot of the data suggests some of these treatments are equivalent with respect to cancer control, then the decision on what to actually choose can oftentimes come down to what are your potential side effects going to be.
Right. And Dr. Schaffner, in a similar fashion, What services would you possibly offer to men prior to their treatment if they were to come in and see you pre-treatment?
That's a great question. I often will speak it to your physicians, or when we're out and our marketing staff will come out and let the doctors and let the community know that the pre-treatment, it is much easier to learn how to use a muscle before it's been traumatized. And so when you come and surgery is traumatizing, it's calculated, right? So you're going in, you're doing a surgical procedure. Oftentimes there may be catheters involved, which makes the pelvic floor not have to work as hard. And so if we think, and we put this in the light of, let's say, just a regular muscle surgery, like a knee surgery, we use our legs all day long and we know how our thighs and our quads work, but the pelvic floor, we're not quite sure. People are not quite aware how that pelvic floor works, what part of it's voluntary, what part of it's not, what can we control, what can we not. Some of the habits that patients have beforehand relative to even how much water they drink in a day, that is a huge issue that I see coming in with patients after surgery. Is they have incontinence, therefore they think it's okay to not drink water, which leads to a host of other problems, including dehydration, more joint pain, fall risk, and a lot of other things that can cause complications. So we can educate and counsel on those behavioral changes that need to occur, whether they have surgery or not, but also how do they use their pelvic floor? How do they get it working? How do they know where it's at? How does the whole system function to help them have a better quality of life before they have radiation or before they have surgery or something that makes it so that maybe they can't feel as well, or, how to know how to turn that muscle on and off.
I can't tell you how many times I've turned to a patient and said, we're going to have to teach you some pelvic floor exercises. And they look at me and they go, I can't get down on the floor. And I go, no, that's not exactly what I mean.
Right.
So it really does take a lot of explanation for people to understand that there is a part of your body that you quiescently need to take care of. And it's not like moving your biceps and lifting weights. It's something you have to actually learn how to target it. And that's where your services come in very, very handy and essential.
And incontinence is not a normal part of aging. It's been something that men and women have had to deal with quite frequently because of not whether you bear children or not, but it's been a very taboo conversation. And so people still don't want to talk about it. And it doesn't have to be a normal part of aging. It is something that we can definitely control and have some measure of control over as we do age or through whatever life process takes us.
Right. And you don't need to be relegated to diapers.
No.
And that's why we're here tonight, to have that
Or your
conversation.
home. Or your home. Some people refuse to leave their home because of it. So it can be quite debilitating.
Yeah. Dr. Sandberg, can you do me a favor and define the different types of incontinence so that people can kind of understand what we're talking about?
Yeah, absolutely. So I think one of the most common types of incontinence that men will experience after prostate cancer treatment, just to keep it in that context, would be stress urinary incontinence. And stress urinary incontinence, I think to explain it most simply, is just incontinence due to lack of support, whether that be to weakness in the muscles that were once necessary for incontinence, or potential damage or absence of those muscles after of surgery. Those men, and it can affect women too, but leakage, it tends to occur with increases in intra-abdominal pressure, with coughing, with movement, with sneezing. And it can vary quite greatly from maybe a few drops here or there when somebody bends over to complete and total loss of control and having no support at all. And that tends to happen in prostate cancer treatment due to damage from surgery or radiation to the external urinary sphincter, as well as the intrinsic sphincter, as well as if the prostate's removed, sometimes there's direct damage around the bladder neck, which is also important in incontinence. In addition to that, you can also have urge incontinence. And urge incontinence happens more related to increased pressure within the bladder that's happening when the bladder feels as though it needs to empty, even if it may not be as full as it can be or as full as it once was. And so these patients tend to leak more with that urge to really have to go badly. They rush to the bathroom, they can't get there on time. And sometimes that can occur as a result of secondary effects from radiation, for example, either pretty close to the treatment timeline within months, but some other times years down the road. In my experience, I find really most commonly it's a mix of two, with one of them being most predominant, between stress and urge. And it's part of our job as well to try to figure out which one is affecting the most, because I also find that even in men who have had radical prostatectomy, they've heard this maybe before from their other doctors, and I end up talking to them, and we might do some additional testing, and we find out they actually don't have stress incontinence. They have urgent continence, and that's important to figure out because the treatments for the two are very different.
You know, it's interesting you're saying that because Dr. Schaffner and I were having a conversation just before we went live about how some men who have these long histories of outlet obstructive symptoms from a benign enlarged prostate, then all of a sudden get diagnosed with prostate cancer. And then when they have that prostate treated at that point, then they develop all the secondary side effects of urinary urgency and urgent continence, or sometimes even progressive stress incontinence, because their bladder now is hyperactive or overactive. And that's because of all the years of trying to outwit the prostate that they've been suffering from. Do you have any like discussions that you have with patients, and how do you apply, like, say, the AUA symptom score or IPSS before you go ahead and do these things?
Yeah, so I absolutely review. I mean, I'm glad you brought that up because the AUA symptom score, also kind of synonymous with IPSS, is a series of questions that ask men about their voiding symptoms. And in general, they can kind of be divided into storage symptoms. They can be divided into obstructive or emptying symptoms. And so it's important to really kind of flesh out with the men where their symptoms lie and what's really causing the issue. So, when do they experience, excuse me, when do they experience incontinence? Is it around the clock? Is it daytime only? Is it nighttime only? Is it, with that physical activity, or is it when they're just sitting on the couch watching TV, not really being physically active? In some cases, it's not so clear. And then additional testing such as urodynamics, cystoscopy, voiding diaries, which we sometimes ask them to take at home to actually objectively keep track of what they're drinking and how often they're using the bathroom and leaking, can help differentiate the two of them.
To try and continue on this train of discussion, once men have their treatment, whether it be radiation or surgery or cryotherapy, how soon do you start evaluating and treating them for their incontinence and their erectile dysfunction?
Well, I think almost immediately in some respects is the right answer. And even beforehand, we talked about some of the preemptive things that can be done. I would say, though, typically from my standpoint, when I tend to see men, it's after they've already tried potentially medications, when they've already tried physical therapy, which I think is an important tool for every man who undergoes prostate cancer therapy. When I talk to men about surgical therapy, and I'll just go from that route because it's what I have expertise in, oftentimes we won't necessarily think a man's ready or offer surgery for at the earliest 9 months or up to 12 months after their treatment is completed for their prostate cancer, because we do see that while rates initially of urinary leakage may be high in the first month or two after radical prostatectomy, for example, many of those men will go on to regain or at least significantly improve the level of incontinence, and they may not end up needing a surgical procedure. But to be more direct about your initial question too, I'd say it's important to get involved with treatment and evaluation of that quite soon, within the first month or two, because men can also benefit from other interventions besides surgery to help hopefully have them avoid it.
And I know before you did mention two things. One is a role of behavior modification, whether it be dietary, lifestyle modifications. And also you mentioned kind of like expectations, realistic versus unrealistic, or actually how some expectations are important to some individuals and really not important to others. And so it's really important to ferret those out in your history taking and how you proceed. So that was really helpful what you brought up before. And I just thought I'd bring it back again. Sure. Dr. Schaffner, this is the part where I think you're going to have to break out your pelvic model. And the reason is that a lot of us, really don't know pelvic anatomy, and especially our patients, they really don't study their pelvis because it's not the kind of muscle that they ever were trained to take care of until it's not working. And so can you talk a little bit about how you evaluate the patient when they come in with urinary incontinence, and what are some of your first steps?
Absolutely. So first thing off the bat, I ask if they've ever been to physical therapy and been to a clinic. And we take them into a private room. All conversations are taking place in a private room. And I can say with a fair amount of certainty, most appointments are an hour, and the first 30 minutes are just conversation. We need to get a grasp on those behavioral habits that the patient may have. How much water are they drinking? So we ask a bunch of questions about their urinary health, their bowel health, and their sexual function. And so that helps enable us to write goals for that meet the patient's needs. For example, I've asked plenty of patients, are you sexually active? And they tell me no. So their erectile dysfunction isn't even an issue for them. They were not sexually active before surgery, so it's not an issue. So it's things that we don't even need to go down that road because they aren't and they don't plan to be. But relative to bowel and urinary, we also know that if somebody has severe constipation, it's going to be real, and they've got incontinence after surgery with prostate cancer management, that's going to be really hard. We got to get the bowel management under control first. And so we ask a lot of questions there. After we do that, we do go into an evaluation, and that depends on where the patient is in their time scale. If it's within 3 months of that prostatectomy, we're fairly hands off. We will do some external touching right around the perineum. And so I did bring my pelvis with me. My pelvis does not have skin though, and I'm going to try to not make myself disappear. But this is, so here's the sacrum. Whoop, I disappeared. There we go. So here's the sacrum up at the top here. There we go. And this is the pubic bone down at the bottom. And so we will have people undressed if they're comfortable. We keep this at their comfort level. So it may not happen on the first visit, but sometimes we'll just be touching right around the rectum here or around the anus to see if they actually can contract their pelvic floor. And so relative to hands-on evaluation, that is a big part of what we do. We make sure that their hips move appropriately. We make sure that they can use their back muscles. But a lot of the continence with pelvic floor is like what you mentioned earlier was the pressure management. So if I ask somebody to do a Kegel, which is the layman's term for a pelvic floor contraction, if I can't see what's happening here at the rectum, I can very easily make a poor assumption that possibly they are contracting that pelvic floor up, and it should be retracting in towards the body. But if I can't see it, I don't know for sure. And I have had cases where patients were not comfortable doing that evaluation on the first day, but they were after they got to know us, and they actually were what we call valsalviating, or they were and bearing down, and they were pushing out, which is actually increasing their incontinence. So that is an important part of the evaluation, is making sure the person can do that pelvic floor, they can do the Kegel, they can contract those muscles up. And then from there, whatever else has to happen, we do breath work. We check to see how they're breathing, because the respiratory diaphragm opposes the pelvic floor diaphragm. So as we take a breath in, that respiratory diaphragm is going to put pressure on the abdomen. And if the pelvic floor is so rigid that it can't move, then it can actually increase their incontinence. So there has to be mobility so that as you take a breath in, that pelvic floor can descend and it can come back up. And then the abdominals from the front, same thing. You have to be able to create that pressure so that when somebody has to actually go to the bathroom, it's kind of like squeezing toothpaste. I hate to use that analogy, but it works really well. You know, the pelvic floor is kind of the cap of the toothpaste. And if that cap is on too loose because the pelvic floor isn't strong enough, then as they breathe, or like Dr. Sandberg had mentioned earlier, they bend over, they cough, they sneeze, they laugh, they do anything that increases that intra-abdominal pressure, it'll cause the incontinence. So we evaluate all those motions, see how they're breathing. And interestingly enough, your pelvic floor is not that much more different than mine. They are very similar. So if I take that pelvic floor and flip it to the inside, what's inside the body cavity, most of these muscles are exactly the same. And so whether it's you or whether it's me, so relative to how to use that pelvic floor, they function very, very similarly. So I can have, relate to them relative to some of these issues. So, and find solutions that work.
And for the women who are actually joining us this evening as part of our families who are involved in supporting the men who are prostate cancer survivors, what kind of advice would you have for women as to when they should seek out a physical therapist to have that discussion about pelvic floor therapy?
I would do the same thing for women that I do for men. If you cannot control your urinary or bowel continence, and it is impacting your life in a way that is negative for you, you need to come seek help. For some people, that could be once they're already in a full-on diaper at night and they don't want to take it anymore. For other people, it could be they're barely spotting in their underwear. Maybe they're coughing and they're sneezing and they're laughing and they can't control those last few drops of urine, and they are very uncomfortable. Everybody's level of incontinence is like Dr. Sandberg had said, it's a pretty sliding scale of what people will tolerate. And so when it starts to significantly change your life, or even moderately, whatever level, you come and see a therapist. And I give that advice for every functional limitation. I give the same advice for people who are looking at orthopedic surgeries, for knees and hips. Don't wait till the last minute and you can no longer walk and jog and do all the things of life that you want to do. Do it when it starts to impact you, because then the muscle is actually stronger and you haven't gotten all the way down to the battle of the barrel of defeat before you're coming into us and we've got to climb out of this big hole. You're relatively close to the top or someplace close, and we've got more to work with. So sooner than later is always better. And, I can't speak for every physical therapy place in the world, but I can speak for Neil King Physical Therapy, and we do free consults. So we always have people come in and just give us a phone call. We are free to answer questions anytime.
And can you talk a little bit about biofeedback and electrical stimulation?
Mm-hmm. So we use those when we need those. We have found that our hands do great, but there's some patients who either need to take something home or they need a little more extra feedback. And so we can do biofeedback and external stim in two ways. We can apply those electrodes externally. We can put them on the abdomen. We can put them on the area of the glutes. And biofeedback is a device that we can use electrodes or sensor pads more so that hook up to the patient, and it gives them a box, or we hook it up to a computer program. And it's able to sense the muscle activity at the pelvic floor muscles. So when we ask them to contract, it may be, if they're just holding on to the device, it may be some bars that raise up. If they're working with a computer program, it may be a flower that opens up and expands, or it could be balloons popping. It can get quite creative depending on the program we're using. Or if we're asking them to relax, it goes the other way around. And so we can give them and tie a visual feedback to what they're doing functionally. On the other hand, if somebody's having a very hard time contracting their muscles, we can hook up electrical stim. Same thing. It can be applied externally or internally. And I can tell you that might sound a little frightening, but unlike many other medical professionals or professions, physical therapy is one where anything that we do to a patient, we've actually had done to us. And so electrical stim to the pelvic floor is something I have had done to myself as well. And it is simply inserting a probe and giving I know this sounds terrible, but a little bit of an electrical charge to those muscles, because muscles do work on electricity, but it feels like a pressure. That's what it feels like to you as the patient. It feels like a pressure, and you can feel that pressure right in your pelvic floor, and it helps those patients find those muscles and work them. And so those are two of the tools. The other things we can sometimes use for women, we can use pelvic floor weights. We don't use those for men. They're inserted vaginally. They don't tend to work so well inserted rectally, so we don't use them. But for a woman, we can actually use a pelvic floor weight, which also gives them that pressure sense to help strengthen the muscle over time and incorporate into their daily program.
That's great. Thank you very much. So a couple of things. I'm going to have Dr. Sandberg now share with us some of his surgical expertise and talk a little bit about some of the surgical options for those individuals who have urinary incontinence issues. And that actually gets me to a question from somebody listening in right now saying that he's now 4 years out from his radical prostatectomy and he still uses 3 pads per day. Is it too late for him to see any improvement? He's already had some pelvic physical therapy. So before I go on to Dr. Sandberg, Dr. Schaffner, any more type of physical therapy you'd want to offer this patient?
I absolutely say yes, come and see us, because what I have found is not all therapists are alike. And so sometimes I will have patients who come in and maybe he got his pelvic floor physical therapy within that 12-week, when we really do not want to do an internal assessment. That rectal wall can be kind of thin. And so we don't do anything internally within that 12 weeks. And maybe he is not doing his pelvic floor contractions correctly. 4 years out, we don't have to worry about that so much. So we can do a little bit more of an intense, comprehensive evaluation to make sure that he is actually breathing correctly, contracting the muscles correctly, and then also what the surrounding tissues, obturator, internus, and all the other muscles around the hips and the abdomen are doing. So I don't think it's ever too late, just mostly because I don't know what he's had already.
There you go. And so Dr. Sandberg, what are some of your thoughts if you were seeing this patient?
Yeah, absolutely. So I echo that sentiment wholeheartedly. So especially when I see a man and it's been a little bit of time. So first of all, no, it's not too late to have improvement, with proper therapy. But a lot of guys too, when I counsel them on surgery, surgery is somewhat, permanent. I mean, with these treatments, we're implanting devices, which I'll talk about in a moment. And technically, yeah, you could go back and remove them. But for the most part, surgery, once you choose to do it, you can't really go back on it. And so I always encourage men to explore that option of physical therapy first, or in parallel with getting ready for potential surgery if their incontinence is severe enough, so that they can at least convince themselves, I've done everything I can. And maybe I've made some improvements, but I'm still not quite where I want to go. And if they're in that camp, then I talk to them about surgery. 3 pad per day leakage, for example, after 4 years, I mean, it's not a high volume of urinary incontinence, but it's enough that it can be distressing to a man still, and we're still wearing pads, obviously. The first surgical option for men with stress incontinence, particularly that affects guys after radical prostatectomy, would be implantation of a male sling. A male sling is a mesh device. It's basically a very thin strip of mesh that's placed beneath the urethra. So an incision is made in the perineum, the area right between the rectum and the scrotum. We dissect down to the urethra, and we do what's called mobilizing the urethra. We find it and we detach it a little bit from some of the attachments that it has in the pelvis, so that it can be a little bit more mobile. And then we implant a sling to help provide extra support. So it's almost like a hammock that sits underneath the urethra. We're able to tighten that sling in real time in the operating room to our desired tightness. And it essentially gives that man more resistance, more outlet resistance to prevent urinary leakage. This tends to be offered for guys with what we consider mild to low volume urinary leakage. And my general cutoff is about 3 pads per day. You may find other surgeons who would go as high as 4 or even 5, especially if they're convinced that, it's a light pad. Some men change their pads the first drop of urine that hits it, and other men will be completely soaked before they change it. So you have to get that history too. But that's one option. What's nice about it is that it's a single surgery that takes about 45 minutes to an hour. Patients can go home the same day, and it requires no extra effort on their part to urinate other than what they're typically are used to. The bladder feels like you got to pee, and you go pee. The alternative is an artificial urinary sphincter. And this is a device that has 3 components. It has one component that's a cuff that wraps around the urethra and provides pressure. That cuff is connected by a series of tubing. One set of tubing goes down to a pump that's in the scrotum that the men actually will feel once they're recovered through the skin of the scrotum, and have to press a button on that pump to actually open up the sphincter. So you can imagine, in a normal circumstance, the sphincter is like this around the urethra. They press a button and it moves fluid in that cuff out of the cuff and into a balloon, so that it then looks like that. And the balloon is the third component that's implanted in the lower abdomen. That balloon holds the fluid automatically once they press that button for about 60 to 90 seconds, allows them to pee, and then automatically that sphincter closes back down around the urethra, and that restores their continence. And that's really the gold standard surgical treatment for men who have higher volume incontinence, may be wearing multiple Depends or adult diapers each day, have very little urinary control. And we've taken men routinely from 10 pads a day, 24 hours, even during sleep, they're leaking, to either being completely dry or maybe just wearing one light pad per day for safety in cases where they're super over physically active, where they might be prone to leakage in certain scenarios. That surgery takes about an hour to 90 minutes. I keep most of my patients overnight in the hospital one night, but some urologists will send them home the same day. But it takes about 6 weeks to fully recover before they can start using it. So we actually implant the device, we leave it deactivated, meaning they continue to leak while they're recovering from surgery. And then in an office visit 6 weeks later, we will activate it, and they come in leaking and they leave the office that day dry. And I've had men in my office crying because it's been such a life-changing moment for them. And so, if it's this distressing thing in your life, it can really be a game changer.
And the satisfaction rate from either the sling or the artificial urinary sphincter is quite high, isn't it?
Yeah, it's very high. It's greater than 90%, even greater than 95%, depending on the population you ask and how you phrase the questions. And I think that satisfaction rate is so high because the AUS artificial sphincter, for example, has been around for almost 4 decades. Yeah. And so it's reliable, it's proven. There are literally hundreds of thousands of these in men that have been implanted. And so the satisfaction rates are so high because it's a very, well documented procedure, a well-practiced procedure, and one where we're not guessing. I mean, we know how to perform it and perform it well.
And just to ask you a question that came in while you were discussing this, an individual who's watching right now was asking about a situation where he had a transurethral resection of the prostate 15 years ago, and he's still having urinary urgency. And he just wants to know, is there some type of therapy that can help after this long period of time?
Yeah, so I think, urinary urgency after transurethral section of the prostate is relatively common. And I explain it to men a lot of times in that it may be related to the fact that he had a very large prostate and the bladder was sort of working against this large prostate for many, many years and decades. And it's possible that there's been some remodeling of the muscle tissue that now is causing that overactivity. Yes, there's absolutely therapy that can be pursued, although his TURP was already performed. It was performed 15 years ago. And so, number one, we got to make sure that that prostate still is okay. There hasn't been regrowth of tissue and that he doesn't need more prostate treatment for that. But if that's not the case, then we also have to sort of take a significant, very thorough history, possibly do some additional testing and determine if he might be candidate for oral medications, physical therapy, PTNS or Botox injections, a lot of different options for overactivity of the bladder if that's the true diagnosis.
And Dr. Schaffner, just out of curiosity, do you think there's a role for maybe rapid fire Kegel exercises in individuals like this, or some other option?
There can be. So some people, we see urgent continence all the time, and it can be a structural problem, but it also can be a behavioral problem. As we talked to early, part of our pelvic floor we have control over and part we don't. And so it is functions under the autonomic nervous system, so our fight or flight nervous system. So if people tend to tap into that, fight nervous system or fight or flight sympathetic nervous system too much, we can get anxious. And so we feel that first urge, and then people get more anxious. It fires up their nervous system some more. Their bladder gets more hyped up and more overactive, and then they got to go. And so one of the things that we look at is calming their autonomic nervous system down so that they're not fighting against themselves. So when they do feel that urge, it could be a little bit, I hate to say psychologically and behaviorally driven, but it can be. And so that's where one of the functions of the abdominal breathing comes in. It helps calm that system down. But then we do a lot of self-talk. So one of the things I will tell people, especially at night when they have to go to the bathroom, number one is stop drinking water 2 hours before bedtime. Your kidneys and your organs are meant to sleep at night as well. And so if you are you're trying to catch up on water for the day and you're dumping a ton of water in at night, that's not the time to do it. Start at breakfast and carry on before 2 hours before bedtime. And just take whatever water you need for medication. So one of the things is waking up at night and they're like, I gotta go. I'm like, well, you need to calmly tell your bladder that there might be a bear in front of the bathroom and he doesn't leave but once a night. And so we give them some breathing exercises. We give them some self-talk exercises. It may be rapid Kegels. You will hear those called knacks sometimes, which basically means turning your pelvic floor on and off very rapidly. That doesn't work for me. Long pelvic floor holds work for me. So if I really got to go, I can kind of do a sustained pelvic floor hold until that urge passes. And then I talk very nice to my bladder. And I know that sounds ridiculous, but it does work. And I just tell my bladder, hey, listen, here's what we're going to do. We're going to walk really calmly to the bathroom. We're going to be super calm and I'm going to breathe while I take care of my undergarments and, sitting on the commode. Which leads to another point. We women, we only sit for the most part. Hovering over a toilet is awful for our pelvic floor because it doesn't let it completely relax. But for guys, they may be storing sometimes. They may not be completely emptying. And so in those cases, that can lead to that urge because there's a residue that's left behind that they aren't fully emptying. So that's another behavioral thing. Oftentimes I'll say, hey, I know you're used to standing, but have a seat. Let those muscles relax completely so that you can fully empty out your bladder and nothing's being left behind. So.
Well, moving on that same train of thought, do you have any other supportive or long-term services that you might think will be helpful that you can offer for cancer recovery?
We do. So unfortunately or fortunately, we've had a couple clinicians at the clinic who have been through cancer treatment, myself being one of them. And I've got one or two other clinics. So we understand the journey of having had cancer, the post-chemo, the fatigue, whether you have confusion, neuropathy, the neuropathy that can happen after chemo, especially if you've had to have chemotherapy, can impact your balance. The fog and mental confusion can also, so we offer all kinds of therapies to help restore all those functional limitations and reduce those limitations for patients, whether it is balance, the fear of falling, because obviously if you've got neuropathy and you can't feel your feet as well and your balance isn't as good, and then you fall and break a hip, that's a big problem. That's a big problem. So we try to alleviate those by providing services to alleviate their joint pain, get them back into movement, help with appropriate weight management. Some people gain a lot of weight with cancer treatment. Some people lose a ton of weight. There is a spectrum on there. And so overall health management is something we can do some counseling with dietary needs, different dietary needs to help with it if they're obese or if they're underweight, while we're getting getting the muscle back on them and getting them stronger and moving back into life.
And just out of curiosity, do you have any role involved in Pilates or yoga therapy for individuals as they're recovering?
For sure. So I have been trained myself in Pilates, and I've done yoga a ton. I've got different levels of people at the clinic. What we really do is during that initial interview program or interview with the patient, we ask what they like to do. Because if I institute a program, let's say you love yoga, Dr. Lutz, and Dr. Sandberg loves Pilates. But if I build a program for yoga for Dr. Sandberg, the compliance is going to be really tough because he's not a yoga guy. He's a Pilates guy. Same thing for you. If you want to do, yoga and I give you a whole Pilates workout, it's not going to work for you. So all the therapists in the clinic are familiar with both methods. And we really tailor a program around what somebody likes to do. Maybe you like to lift weights. Great. Then we'll figure out a program for you to lift weights. If you like to sit on the couch, I'm going to figure out the least resistive barrier to get you off the couch. And that might be riding a pedal bike in front of your television. It might be taking a walk every 5 minutes, whatever works for that person to get them up and moving. So.
Well, thank you and appreciate all your help.
Mm-hmm.
So, Dr. Sandberg, one area we didn't touch on at all is really erectile dysfunction, risk pre and post treatment. And do you have any perhaps preemptive options you'd like to discuss with the individuals tuning in tonight, and maybe some of the interventions that you do post treatment?
Yeah, sure. So I do think that, it's important to have a discussion around erectile dysfunction as well, because it affects a lot of men. I would say, based on the data, more men actually after prostate cancer treatment than urinary incontinence. And the degree to which, we mentioned this earlier, but the degree to which you focus on that really depends on the man and how important it is. It's important to know, are they sexually active or not? Do they plan to be afterwards? And what is are they married? Are they dating? What is the status of what their goals are so that you can help them through that? I think, first and foremost, erectile dysfunction can sort of be a first signal for other health issues. And so I talk to guys about things that can affect erectile dysfunction beyond just treatment for prostate cancer, but they can be things like diabetes, obesity, cardiovascular disease, hypertension, other medications that they might be taking for other medical conditions, prior surgeries that may not be related to prostate cancer per se, but could be related to the GI system or the rectum or whatever it might be. And so trying to optimize their health from all those standpoints prior to undergoing prostate cancer treatment can be important. The other thing is there is some evidence to suggest that a coin was termed several years ago called penile rehab for men who have undergone prostate cancer treatment, which is the early intervention of use of medications like Viagra and Cialis, as well as possible incorporation of a routine with a vacuum erection device or a penis pump to help keep blood flow within the penile tissues as much as possible post-operatively or post-radiation to help recovery of erectile dysfunction. Because many men, maybe upwards of 50 to 75%, will have erectile dysfunction within the first few months of a radical prostatectomy, for example, but a large percentage of those, more than half, will recover their function back within 12 months. And so I work with those men early from a overall health standpoint with use of medications. And we typically start with oral pills and medications. We start with things like vacuum erection devices if they're willing. But if those aren't enough, then there are also injection therapies that can be provided to the penis, which are medications that don't rely on the metabolism of swallowing a pill and having it get into the bloodstream, but are going directly to the source. There are newer therapies out there, ultrasound shockwave therapies to the penis that are still relatively new, but being further investigated. And then from a surgical standpoint, if those methods are not working, then there is also a surgical option to implant a penile prosthesis to allow the man to have a rigid penis and regain the ability to have an erection. And so, many men aren't aware of that, or they had a prostatectomy 10 years ago and are just learning about it. And that can be, eye-opening for them. And it's important to know, similar to one of the other participants' questions, if it has been 5 or 10 years, that's not too long of a time for a man to still potentially recover sexual function, with or without a penile prosthesis surgery. And they come in different shapes and sizes and sort of configurations. And those are all things that we talk about in a visit like that.
Why do you think it seems like a bridge too far for a lot of men to make that jump from the oral medications or penile injection therapy to opting for a penile prosthetic device?
Well, I think a lot of men almost, in my experience, they feel like they need permission in some cases to do it. They need to understand that they are worth the quote unquote hassle of undergoing an operation. And they think, well, this, erectile function is not life or death, but it is a large quality of life issue. And so some men I've had in my clinic really say to me outright, I don't know that other people think that this is an important enough issue for me to pursue something like a surgery, but I feel like I'm missing something, and I feel like it's important. And sometimes it takes a little while to gain that realization and allow them to give them permission to have the confidence to be able to do that. I think too, it is different to take a pill, 60 minutes before, sexual activity and it work flawlessly, versus having to undergo, a surgical procedure with an incision and a recovery period. But I find that with a penile prosthesis, satisfaction rates are again upwards of 95 to 96%, because we're essentially giving men something back that they've lost, and it can help them in their relationships with their partners. It can help them in future relationships and their confidence to get back out there in the dating pool. I had a gentleman who I put a prosthesis in, and I saw him literally today in my office. He was 6 weeks post-op, and he has not dated. His wife unfortunately passed away. He has not dated anybody in 6 years. And he told me he left the office that he was preparing to go on a date within the next month. And so, a lot of guys, they know that it's important to them. I think deep down, but they sometimes need the education and sort of also an ear to lean on and have somebody listen to them, because it's also something that they are not talking about with their brother or their son or their cousin. They kind of suffer silently with it sometimes. And I think that's where there's sometimes some hesitancy, and it'll oftentimes take 2 or 3 visits to kind of, in no way try to convince them of it if they don't want it, but to explore those. It's almost like a therapy session. Sometimes I'm in the room with patients for a long time, trying to help them understand what their own goals are and whether or not they want to have this done. And sometimes they choose to, and sometimes they don't. And either way is fine with me, as long as they're moving toward where they see themselves and where they want to be.
Thanks for your insight. And I just have one final question actually for both of you, and I will go ahead with Dr. Sandberg, since he's been talking for these last few minutes, because this is more of a continuum. And my question is what do you believe is going to be the future of your specialty and your contribution to the health of men?
Yeah, I think that, the future of our especially of urology in general, is going to continue to be not only prostate cancer treatment, but recovery. And the MIU Men's Health Foundation is absolutely a leader in that. And I think everything that the foundation is doing right now, has done in the past, is only going to help men continue to ensure that they get the best treatment possible. So that includes research, it includes funding for new therapies that I think are going to end up being very different 20 to 30 to 40 years from now than they are right now. but also better treatments and therapies for those inevitable side effects when they come.
Thank you. And Dr. Schaffner, your thoughts?
What I think will happen with my profession is as access to my profession grows and the awareness of what physical therapists, what our education is and what we really know, I think that patients will start coming to us sooner. They will start coming to us, before it's been years. Maybe it's after they've already been discharged from Dr. Sandberg or somewhere in between. They'll come to us directly once that's enabled in this. We can already do that a bit, but I think that's what's coming is they can come directly to us. They don't have to ask a physician's prescription or permission or anything. And we can evaluate where they're at in their life and make recommendations. And those of us who are appropriately trained in pelvic floor physical therapy and have the experience to know what our limitations are. When I look at how my field has changed over the years, the body and way muscles work hasn't changed a ton, but our knowledge of how it works has. And so we've got different tips and different tricks and different techniques to help get patients onto where they need to go. And I think it can become a far more collaborative experience where right now I see a lot of patients from doctors to me, where I think it might come the other way around, where we are actually seeing patients sooner. Maybe we're seeing them even earlier just with some of the occlusive problems, and we are actually sending them to you guys. And so it becomes a little bit more of a two-way street in that matter. So just earlier care, earlier intervention.
And I really do want to thank both of you because what you've actually shared with us tonight is about being proactive and integrative and how it can be helpful to patients pre and post treatment. And I think that really is something that we should all focus on and try and be better at. And I know that we have not done as good a job as we really can. So hopefully in the future we shall. I want to thank both of you for being here tonight. I want to thank our sponsors who bring us this event, because without their sponsorship, we can't afford to do what we need to do to help our community. Those being Boston Scientific, Neil King Physical Therapy, Lantheus, Planet Fitness, Blue Earth, and the American Cancer Society. We are looking forward to 2024. Believe it or not, we're already thinking about Blue Monday, June 10th, 2024, where we kick off International Men's Health Week and start celebrating the health of the men across the world. On that same day, we'll be holding our Cogs and Kegs event at Griffin Claw, thanks to our partners at Griffin Claw Brewery, who actually open up their venue to make us feel at home for the evening and share it with our first responders. We'll have our Mulligans for Men on June the 13th, which will be at Topgolf. And then our final event on that week, Run for the Ribbon for prostate cancer survivorship for men and their families on June 16th. If you're into podcasts, we have a podcast series called On Call for Men's Health. Our most recent one that just was published and is available on YouTube is Landy Maduro, who was recently interviewed and shared her journey and her discussion about prostate cancer survivorship for a series of African-American men and the disparities in health and opportunities for Black men as they go through their prostate cancer journey. It's a very moving podcast, and I hope you'll take advantage and listen to it. It is available on YouTube and Spotify. And again, if you wish to have any further comments or questions answered, you can feel free to reach out to our 1-866-HELP-MEN line, or you can reach out to Andrea Hamilton, our executive director, at our info@miumenshealthfoundation.org. I want to thank you for joining us this evening and have a great night.